So I do want to thank. We have sponsors to thank. I want to thank EMD Serono and Sanofi, Novartis, TG Therapeutics, and Genentech for being our sponsors of today's program. We did have people that were exhibiting as well, and I believe they were EMD Serono. Sanofi was not there. Novartis was there. TG Therapeutics was there. Genentech was not there. I'm sorry to say all these names, but I'm not there, so I really can't see what's going on. All right. And I know that the National MS Society was also there, so I want to thank them greatly for helping out and for helping to get the people coming to this program. Dr. Ann Cabot, she's a great local doctor. We've been, hearing about Dr. Ann Cabot for quite a while now, and we have had Dr. Cabot in the past present for us as well. And, you want to hear about a rural town doctor. I mean, this is it. I mean, this is, medicine is held a little bit different in the rural areas of the United States than it is in the metropolitan areas of the United States. And sometimes they have to allow for more things that, metropolitan doctors may not want to even look at or do, and, they don't have time for. But out in the rural areas of the United States, doctors such as Dr. Cabot to expand what else is available for patients. And so there are different wellness programs, and she'll be speaking about wellness as well as the medications, new things that are happening in the world with multiple sclerosis. And so, Dr. Cabot, I want to thank you. And I don't have your intro, unfortunately, in front of me, so you could tell the world about yourself. All right, and take it away. All right. Thanks a lot.
Awesome. Thank you, Stuart. It's awesome to see so many friendly, familiar faces here in the audience today. And I just want to say before we get started, if you're at home, there's like a bright light, so I know I'm being videoed. Please get a piece of paper and something to write with. So hopefully you can all at your desk find a piece of paper, and maybe Lynn and you guys, if anybody has like an extra pen we could share, if somebody needs a pen at the table, that would be great, because there's going to be a little homework. All right. We need a little active participation while you have your lunch. So just forewarning you. So I work in Manchester, New Hampshire at the Elliott Hospital. And I've been in New Hampshire for over 20 years now, and I've been treating MS patients for over 25. So it's a real passion of mine to help people with MS. Try to live the best life they can live with this condition. So it's awesome to be invited here by Stuart, and also hopefully you'll get a chance to look at all the programs that they do through MS Views and News. So let's see. All right. Laura, you knew I wouldn't be able to advance that slide. Let's see what's happening. I hit the green for go, I'm guessing. Okay. Oh, I'm still, no, can you come over and look at what I'm seeing? That's okay. I don't need to see my own profile there. All right. So this is why I was giving you guys paper. Does everybody have a little piece of paper and a pencil or a pen? Now, just so you know, I had to drag all these pens out of my own desk. So I did make sure that they had some ink, but a lot of them are red because my husband's a school teacher. So, all right. So I want you to name 3 things about MS or symptoms, could be anything that concern you. Now, this is important if you're a care partner as well. You don't even have to write them. You can think about them. 3 things that you want to try to work on with your MS. Okay, so that's what I want to talk about now, and we'll think about it during the presentation. All right, so give yourself a second and write 3 things. And if you're a care partner, write 3 things. So the paper's right there, and there's the homework. And the reason we're doing this is we're going to share these later. So if you're a care partner, a person with MS, we really want to talk about managing symptoms and how we approach wellness. So we have time, because you know me, I can talk for a long time. So we can do this. So, and you may not have much to say, but that's okay. What do you guys think wellness is? What is wellness? When you hear that term, what do you think? Anybody? Do you hear om? Do you like when you do you see a picture like this? What do you think about when you think about wellness? Feeling good. I love that. Okay, so I love that. Okay, feeling good. Anything positive thinking. Great. Sometimes it's not easy to achieve wellness, which is why I think it's so great that Stuart asked me to talk about this today. Because it's something, there's always something we can do, and it's always very positive. So it's really important to try and learn new tricks and make sure you lean on your teams, your doctors, your whole team of support people that we have in the medical community, all the resources that we have, the foundations, the exercise programs, the wellness programs that we have online. So I want to walk through all these so that you can take advantage of them, and hopefully you'll have a feeling good moment, a feeling good day, and you can bring a little more of this into your life every day. Nothing's perfect, nothing's, 100%, but hopefully this will work for you. I love that picture too. You'll see a theme. You'll see a theme of flowers. I do love flowers. So when you look into wellness, these are some of the core domains of wellness, right? So it's not just one thing, but I love the thought of just, if you pull all these domains together, hopefully you'll feel good, right? So wellness incorporates things. So if you read articles about wellness, you'll read about things like mental health and cognitive health, right? Paul was the king of resilience, right? So he was talking about mental health and cognitive health, right? Physical activity, different types of physical activity, nutrition, right? We got a little salad in front of us right now. Social connectedness. I'm preaching to the choir. You're already here, right? So meet someone new at your table. Make a nice connection today. Meet another table. These things are so important. Life satisfaction, right? Trying to pull in some life satisfaction, some meaningfulness, and then talking about lifestyle habits and work-life balance, right? So there's a whole lot of things in that. So we can work on this moving forward. Are you guys still thinking of your 3 things? I hope you are. 3 things? Okay. All right. So here's where it becomes a team sport, this wellness, because I think a lot of us talk about wellness, but then maybe we don't necessarily change what we're doing, even though we kind of want it. So wellness is an active engagement. So that means, maybe there's something out there but you need to participate in that in order to achieve the benefit, right? So an active engagement. So these are behaviors, things that might help your lifestyle, and promote health. So sometimes I do think we get into a habit, right? And it's really hard to break the habit. But sometimes it's how you grew up, right? Like maybe you grew up, I can tell you, I grew up in a Scottish household with a mother who was just a lovely human being, but a terrible cook. We had meat and potatoes, and that was pretty much it. Some soggy vegetables. No kidding, she cooked with lard. Yeah. So, I grew up in a house where that's how we ate, right? So that was sort of kind of a habit, right? And sometimes it's hard to break out of your habits. Sometimes you don't have good role models. Sometimes you don't have opportunities. Sometimes a chronic condition can get in the way, right? So that's what we're here to talk about today. So we want to look at the psychological parts of that, like how do we make change? How do we engage socially? How do we dip our toe in? And if we don't like something, it's okay to exit stage left, right? So, and it's all these things. I don't know if you guys ever saw that movie, Everything Everywhere All at Once, but every time I talk about mindfulness, I feel like that's what we're talking about. Everything Everywhere All at Once. And sometimes I feel like I'm a little overwhelming in office appointments. So I'm really glad they gave me this opportunity to talk about it here. So, all right. Clicker is frozen. Laura, where's there we go. Okay. So, now it's gone like haywire. So what did I do? All right, hold on. 2, there. All right, let's talk about the benefits of social support. Did anyone get diagnosed with MS and feel like they were all alone? I see some eyebrows. Yeah, it's a very scary thing, right? Like when you first get diagnosed with MS, it's a lot of, I mean, I'm not kidding. A lot of my patients didn't even know what it was, right? They never heard of it. Or maybe they heard about it sort of vaguely, but thought it was something else. I had no education on this. And because I've been doing this so long, I mean, there really wasn't the internet when I was doing this. So, people couldn't like Google it. So sometimes the benefits of social support and social interaction is gaining that education and just feeling like you're not alone, right? There's over 1 million people with MS in the United States, almost 3 million people around the world. So you're never alone when you have MS. There's some resource somewhere for you, right? We always have people like the MS Society and Locke's Promise, these groups that really, participate in patient wellness. So that social connectedness is really important emotionally. So you learn from these people as well. So, and this has been studied in many papers, but it helps quality of life. It helps anxiety. Can you guys think of a more anxiety provoking condition than MS? Hi, you're 25. I'm diagnosing you with a chronic central nervous system disorder. It can come and go. It can cause all kinds of neurological problems. You don't know when it's going to happen. Here's our meds. They got a whole bunch of side effects. You're going to have a lot of tests, including one where you go in a tube and it feels like you have a hockey mask on your face. Okay, a little anxiety, right? Now, to me, I do it every day, all day long. I'm like, what's the problem? Right? Like, this is what I do all day. When you're, coming in and maybe you work in an office or you're a teacher or something you've never even, all that's foreign. It's very stressful. So just to talk to other people who've been through it on the other side, they get it, right? They get what you've been through. They may not have the same symptoms. That's not the point. They may not have the same outcome, right? Everybody's MS is different. It's crazy, but still true. But those things can help reduce your anxiety when you realize I'm not alone. I can talk to other people, and you can take a deep breath and slowly calm down and kind of absorb the diagnosis, but also how you're going to manage this moving forward, right? How about care partners? Any care partners here today? Friends, family, care partners? Yeah. So it's scary for you too, right? So it's important to acknowledge that you may also need some support, right? That's really important. And there's support out there for care partners. I know that Elliott Hospital just did a whole conference on care partners for all kinds of chronic illnesses. So it's really an important topic. So let's look at a little more of these things. Anybody have any stories about when they were first diagnosed and they leaned on someone, whether it was the MS Society, MSAA? Did anybody make a call to any of those support groups? Or did you just freak out? Who freaked out? Yeah, baby. I love an honest freak out, right? That's normal. Yep. All right. So what do you think are a few things that might help with social support? Name one. I got a list up here, so if you can read it, you can name it. So it's really small, so I'm going to go through these. So social support can help improve cognitive functioning. Anybody here ever, Paul can raise his hand, ever complain of cognitive issues with their MS? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Right. Cognitive issues are super common with MS. Social connectedness and socializing can help stimulate cognitive function, literally help stimulate cognitive function, right? So that's really important. It reduces depression and anxiety and overall mental health outcomes because we know that people with MS have higher rates of depression and anxiety. Right? So we want to help them not only with mental health provider, make sure they're connected, but also give them resources as outlets, right? So these are outlets. So coming today, a great outlet, right? Coping techniques, learning coping techniques, and social isolation, reducing social isolation. Some of our patients, for example, let's say someone had bladder problems. And because of the bladder problems, they're nervous. They don't want to go to the gym because they're afraid they might have some bladder leaking. So now they don't go to the gym anymore. So that was one of their outlets. They were going to the gym. They loved the gym because it helped keep them fit too. Like it was good, but they also saw people. And now they're not doing that. So now because of the bladder not being treated, they're not socializing. Now they're a little blue, right? So it just starts this spiral of negativeness. And we got to always try to get in there and empower patients to be like, the reason I'm not doing this is because I am afraid of XYZ. So when you talk to other patients, you might figure out, well, how did you do it? What did you do? Did you talk to your doctor and see a urologist? Did you start doing different things or different times of day? Like just a really good support group there to try and help navigate things that may be getting in your way to socializing, right? But lower social support can be incredibly problematic for patients. They feel isolated. There's increased risks of suicidal ideation in patients who have social isolation. They don't participate as much, but staying connected can help a lot of that. So reach out again to the other tables. Make sure you say hello today. And don't forget sleep, right? So what kind of social support is there? There's emotional support. There's instrumental support. Sometimes instrumental support is receiving like practical help. Like I have a partner who helps me, with the dishes because that's a hard thing for me. Or at the end of the day, they help put the kids to bed because I'm pooped. I do the morning run, the morning stuff. There's informational support, and we are blessed to have amazing support here with groups like MS Views and News, MSAA, all kinds of groups. And that helps because when you feel like, I don't know what to do about this, where do you turn? Where do you turn? Where do you guys go when you don't have an answer? Internet. Where do you go on the internet though? Support group. Love it. I love that. So that's a great one. And there's a bunch of different ones. So you can find one that sort of suits you, right? Anybody find one they like, a support group? Yeah. What one? The Misfits. Of course. Good. Anybody else? And a bunch. I love it. That's great. There's in-person support groups. There's one at Elliott. There's tons of online. There's men's support groups. There's Misfits. So there's a bunch. And then this helps building each relationship can be helpful moving forward with that regard too. And sometimes you may try a support group and be like, not for me. And that's fine too. Just don't give up after trying once. Right? That's the key. Like if you try one and you don't like it, find something else. I think that's the whole point. Make it fun. Make it fun. I think Paul's message resonates, the laughter, the humor, just a chuckle at something that somebody else can really understand. Other people may not. So it's kind of wonderful. All right. So why is it harder sometimes to be social? I think this is very important. Fatigue. Anybody here have fatigue? I saw the hands go up with heat intolerance, right? Fatigue, number one, right? Cognitive difficulties can make it challenging sometimes. Even things like hearing loss, which isn't an MS problem, but is a common problem as we age, can get in the way of socializing. So trying to maximize all that is really important. Mobility issues can make it more challenging. Sometimes people are nervous of the stigma that goes along with MS. Right? So sometimes starting with other people who have MS is good and then branching out because other people may not understand quite well. And then I think a lot of times as patients or as providers, we are educators, right? I often have patients come in who say, I had my handicap parking sticker, I pulled into the spot, and when I got out, somebody yelled at me because they didn't think I looked handicapped, right? I see some nods. And I say to the person who tells me that, I say, listen, don't forget that person's trying to protect, people, and you can thank them for their concern. And then you can educate them that you may be able to get into that store, no problem. But because of your mobility issues, your fatigue, your spasticity, you may have great challenges coming back. And that central nervous system MS is often very invisible, but it's your opportunity to educate. So that's an important thing. Sometimes relationships change, and trying to navigate that can be a challenge, right? I mentioned like the family, if you're tired at the end of the day and it's exhausting to put the kids to bed, and now your partner's putting the kids to bed and it really was your role before and now you switched your roles, those things change, right? And so changing relationships, the care partner relationship can be different. It may not be what you expected when you went into the relationship. So talking to other people about how to navigate that, right? That happens with families, friends, coworkers, right? Has anybody had that situation with a coworker? So it can be tricky, but it's really important to keep trying to get support. Sometimes you find support in the weirdest places too. Like You just don't know. You may meet that one person who's like, that's my MS bud. So here's some strategies to seek out. So it's an action plan, right? We got an action plan. How are we going to get more social? So I'm a little bit preaching to the choir because you're already here. So you can share this with your friends who don't go to things. So seek out the support groups. I love the online ones. There's one at Elliott. There's another one at Wentworth Douglas that's in person. So they are around, and you can always go on the MS Society website. They have a list, and they also do virtual. So there's always peer support. Engage in social activities that you're comfortable with. Make it fun. There's a lot of stuff you probably hadn't thought of, right? So you want to find things like clubs that you might like. You know, who knows, it's flower arranging, chess club, whatever it might be. Bird watching. I've had people do that. Birders. And then communication. So this is tricky, right? So you want to communicate with your loved ones. You know, you want to tell your siblings, I'm not coming to, play poker with the family tonight because number one, you bankrupted me last time I came. But number two, I'm tired at night. Can we do something in the morning? This is part of my MS. People can't see fatigue and they try to relate, right? And they'll say, oh my God, I'm so tired too. And it's like, that does not really help. So, but they are trying to help, right? They are trying to understand, but they just don't know. So, trying to communicate with your family and friends about what your needs are and just say, this is what I can do. This is what I'm comfortable doing. This is part of my MS, I think, or whatever, So telling your friends and family those things is super helpful. There are a lot of different websites that also share like how to talk to family, kids, those kind of things about how you're feeling as well. Prioritize self-care. I always kind of laugh at that one because I know how hard that is because everyone's just trying to do everything. But it is, if you can take that minute and just, step back and try to like assess how you're doing and take care of your own needs for a minute first before you try to take care of other people. It is amazing. It's super amazing. Has anyone successfully been able to do that? Like peg out time for themselves? It's hard, right? It's hard. What gets in the way? The what? I don't remember. Exactly. I think that's a big part of it. Anything else? What gets in? Everything. Like what? Work gets in the way. Family gets in the way. Yes. Right. Do the dishes, make the laundry, do whatever, right? Like do the work. Yep. So it is important to try to think of where can I squeak in, 15 minutes to, do something for myself, whether that's, Tai Chi online on YouTube or 15 minutes of breathing and stretching class or whatever it is. Can you take it? Where can you take it from? Where can you take it from? Sometimes it's doom scrolling. We can take away the doom scrolling. It's not good for any of us. Maybe it's, something else like that. But try, and you may see results. Make it a goal, okay? Try to make it a goal. But making a goal is the point, right? So you have to know that you have to do it or you won't do it because you're so busy doing everything else, right? And you got to work at making relationships. It's not easy. I mean, we all get busy and then, you got to peg out time for that too on weekends or whatever. So there is a lot of like hardcore data on how much this helps you. So, I'm a nerd, so we get these journals all the time. But there's a lot of important medical benefits to addressing social connectedness. So it's very physically well for you too, as opposed and emotionally. So let's keep that a priority. So this paper supports the evidence of educational and emotional programming and connectedness wellness programs in adults with MS. So it's everybody's different. That's what the high degree of heterogeneity is. But the other thing about connectedness and socializing and all those things is there's really no bad side effects to it, right? I mean, the worst side effect you're probably going to have from today is maybe you eat too much dessert, okay? So we'll take it. All right. Take a deep breath. Cleansing breath. Okay. So let's talk about stress. Now take another deep breath. Take a deep breath. I have to say, in my office, almost every patient that comes in, newly diagnosed or been diagnosed for a long time, stress is a very big topic, right? Stress, right? And it may be financial stress, it may be medical stress, condition stress, some worried about your family, your other, nothing to do with you, maybe another stressor. Stress is really important. Patients deal with stress. Caregivers deal with stress. Neurologists deal with stress. Okay. But it's stressful. And so we want to make sure that it's not eating you alive, right? So it's not going to help you. Stress is just negative. Stress is so interesting. Stress and anxiety are so interesting because they're biologically necessary, right? You need a little anxiety to keep going. Like if I drop two people in the deadly forest and one of them is super chill and the other one's like, who's going to survive? The one who's they're already. So we need a little biological stress to survive. The problem is no one's jumping out at me here at the old Puritan, right? So it's important to take that stress that's biological and real and try to direct it into things when we need it. If stress is on all the time, it's really negative for us. So I have a lot of patients who say, did I stress myself into my disease? No, you did not. Okay. Literally, they'll be like, did I cause this? I'm like, no, get rid of that guilt. You did not cause your own MS, but you can feel worse when you're stressed, right? What's the first thing that goes when you're stressed? Thinking. I love that. I was going to say sleep, but I think you're right. Thinking. And a lot of my patients complain of cognitive problems, right? So stress, cognitive, boom, you nailed it. You get an A+. Okay, moving on. Sleep. When I'm stressed, I don't sleep. How about anybody else? You guys sleep like babies when you're stressed? I'm very jealous. No, nobody sleeps well when they're stressed, right? That contributes to fatigue, right? Number 2, our big MS complaint. And severe stress can cause, feelings of hopelessness, anxiety, other things that it's really hard to live a happy life when you're constantly stressed. And maladaptive stress coping, what do you think what are maladaptive stress coping techniques? Drinking, yes. Smoking, drinking, drugs, too much food, is that bad? Did somebody just say that? Yes. To manage stress, yes, it's bad. Because that can also cause sleep problems, medical problems, all those other, and you're still not addressing whatever is stressing you out. We all know this to be true, but it's very hard to not feel stressed. So you almost have to engage. Remember what that first slide says, you have to actively engage in order to help make this better, okay? All right. So cognitive impairment can be like a side effect of stress. So what is cognitive impairment? Hard for you to make memories, hard for you to recall things, short-term, long-term, lots of different cognitive problems. And there's different domains of cognitive impairment. Some patients can have problems just sustaining attention. I think Paul mentioned that at some point, right? So, shiny object, right? Short-term memory, very common to have a little short-term memory impairment. Executive function, trying to pull it all together. That's how we explain that. Verbal fluency, information processing speed, it might take a little longer. So these things are important to address because patients may have none of this and patients may have a few of these things, but they get in the way of quality of life. What we want to do is make sure it's not anxiety, stress, insomnia, a medicine, whatever, other things that I might have done to you. So how do we cope with it? So anxiety often hand in hand with MS, and they don't really study it a lot. But we do have scales that we can use to measure anxiety in the office, as well as depression and fatigue. Nothing's perfect, right? Like if you had an awesome night's sleep and you felt amazing and I saw you in the morning, you'd be like, I'm actually doing okay. And then I see you at 3 o'clock, you're like, oh my God, I'm dying. I'm so tired, right? It really depends on when you see your doctor too. It's not lost on us that's important. So keeping track of your symptoms in a little journal can be really helpful. So I really looked hard to find like a peaceful mindfulness picture, but this was the best I could do. But she actually looks like she's sleeping now that I look at it, so I'm sorry. So mindfulness is a technique to help deal with stress, anxiety, but it also helps cognition. So we offer a mindfulness class to our patients with MS, and it's virtual because we know sometimes getting there is a problem, right? And so anybody can take this who would like, but there's a lot of research on why we offer mindfulness. So it's not just arbitrary. We know that this is super helpful. First off, we listen to our patients who tell us all day long, I'm stressed, I'm anxious, I'm having a hard time remember, I can't sleep, all those things that I'm like, well, I don't have a magic pill for that, but I do have this. So you could try this and see how it goes. So the reason that this works is it works on different areas of your brain. And actually, it's interesting because when I first started neurology, nobody would ever do a study like this. They would think you were kooky. But now this is very mainstream topics. Like we talk about this stuff all the time. So parts of your brain, the anterior cingulate gyrus and the hippocampus, are very deeply involved with making memories and helping you perform your best. We often talk to students about this when they have to study for an exam. And really what we're hoping is that you'll keep challenging your brain and making new memories all the time, right? So these things are very tied in with emotion and focus and concentration that impact your functioning, right? So how does all that impact how you biologically perform, right? So if you look at all the things that happen under stress, all these interrelated systems, and I won't go through them, but it's parasympathetic, sympathetic, pituitary, adrenal, like hormones, right? Endocrine systems, your heart rate, right? Like if I get nervous and I check my heart rate, you know, it's going to be like, woo. But it all is a big package. When we talk about treating the whole patient, I really mean it. Like this is important. All of you is important. If one of these problems, if one of these areas isn't really happy, you're not functioning at your best. So we want to give you the tools that you can take with you to try and help those things, right? Now, sometimes it's meds. Sometimes it's a mental health provider. Sometimes it's, you know, a whole bunch of other things, physical therapy, whatever. But sometimes you can take advantage of these things and you're banging out a couple of my checkpoints, right? You're doing mindfulness, you're stress reduction, you're socializing with other people. So it's like a big happy thing, okay? Why don't we do it? Well, it's not part of our daily routine. You got to peg out time for yourself, right? You got to have that 15 minutes, 30 minutes, half an hour. Time constraints are real. Lack of perceived benefit. How many of you deep down are like, I'm not really sure that works, right? So I don't know if I want to invest that time, which is why I pull out the research papers to say, at least we do have research studies that show this can help you. And again, no bad side effects, right? Cost sometimes is an obstacle. I have a lot of patients who want to go get like acupuncture or massage therapy and they can't afford it, but this is free. So, and then the technology. So a lot of our classes are on Zoom, and some people really don't love Zoom, or they don't have a computer, or they don't have broadband, okay? So, you know, internet, sorry. So these are all things that we need to address if a person comes into the office. If a person comes in the office and they don't have a computer, we really start there, because the computer is an amazing way to help patients stay engaged with the outside world, especially if they have mobility issues, transportation issues, that kind of stuff. Anybody do the mindfulness class or a mindfulness class? Do you like it? Yeah? Loved it? Good. Excellent. What do you think it helped with for you personally? Anything? Nothing? Just a great time? All the above? All right, so we're going to switch gears and we're going to talk about diet. So because I saw you got lunch, so I was like, oh, and it looks pretty healthy. Good. So why is diet important? Again, remember I grew up on lard, so into this. It does support you. The more research that goes on, the more we know this supports brain and nerve health. You can help manage fatigue with diet, improve your quality of life. It can help with constipation management. It can help lower inflammation. It can help reduce weight, because excess weight can make balance, movement harder. And it increases fatigue, which is one of the most common symptoms. So trying to be at your goal, what I like to ask patients is, what's your goal with your weight? What's your goal with your diet? We do have a nutrition class that we can offer, and there's a lot of good nutrition information that we can source you to. There's also a lot of bad nutrition information out there, so you definitely want to maybe check in with your primary care and things like that. There is a amazing amount. I'm just thrilled that this is such a topic of educational, research in the MS world. Again, back in the day, I don't think this would have been as important of a topic, but I just got back from that international MS conference. This was a huge topic. So processed foods, try to limit them. Those are foods that come in a package. Anything you can buy at a grocery store, at a gas station, probably no good, okay? So if it's at a gas station, you better think twice. Lots of saturated fats, so that's fried foods, fatty meats you want to really try to keep to a minimum. And I'm not perfect, man. I love milk duds like it's nobody's business. Halloween is my dark time. I have to be really careful, but but I have to keep myself on a ration. Excess dairy may worsen inflammation in some people, and some people say, I got no problem with dairy. Some people say I have no problem with gluten. Some people, so there's individual differences, but definitely staying away from high processed foods and foods in high saturated fats. Mediterranean diet, you've probably heard about it, right? So I tell people, whenever you're kind of like, oh, I got to make a change in my diet, don't try to do the whole that's it. Tomorrow, I'm only eating the Mediterranean diet, because that just hardly ever works. Change one meal a week. Take that one fatty, meaty meal and turn it into a Mediterranean diet meal. But you might find that really easy recipe, that is delicious and, has tons of chickpeas in it. Anybody rolling their eyes? I just love chickpeas. My mom can't believe we're related. But you want to find foods that are rich in omega-3s, shown to reduce inflammation in the gut. We know there's a big link with our gut and the immune system, and it can produce a lot of benefits for patients. My patients come in feeling like, oh, that was amazing. I feel so much better. But sometimes it's really hard to change these things. So when you're stuck, reach out to us. We can set you up with nutritionists. We can show you websites. There's a nutrition class that will be starting up. And these are great. Your PCP can help, and just kind of thinking that way, one meal, I'm going to try this different thing. And then, that was pretty good. Or I didn't like that. I'm going to try something else. Just don't give up. Keep trying. You're doing great. Okay. So it's not a cure for MS. I wish diet was a cure for MS. If I could just RX kale, I would, or hairy spinach, as my kids call it. But it does play a role in how we manage MS. There's no getting away from that now. But that's kind of nice, It helps energy levels, brain health, overall well-being. And this diet is fairly easy, and it's also not very expensive. So big problem that a lot of our people, the groceries are very expensive these days. You can get actually a free nutrition consult at some of the grocery stores in town. Hannaford has a nutritionist that will help you shop on a budget. Yeah, it's great. You can go online and look at that. It's brilliant. Because a lot of my patients are like, oh, it's more expensive to eat healthy. And I'm like, actually, no. All that packaged food is way more expensive than whole grains and all the other stuff. But there's a lot of tricks to that too, so that the nutritionist can help you. So take advantage of all the free stuff, okay? Take the free stuff. All right, so diet's important, social connectedness is important, mindfulness is important. Let's talk a little bit about exercise, okay? So exercise, I always feel bad when I tell people to exercise, because I feel like they look at me and go, did you not listen to me? I just told you I'm super tired. I have spasticity. I have balance issues. And I'm like, I swear to God, I heard you. But what we have to do is tailor that exercise to you, right? Sometimes it's just deep breathing, right? Sometimes you just need a moment to just breathe it out, shrug your shoulders, roll your arms. But anything we can do to help you move more is great. So we may pull in the team. Remember, this is not, MS is a team sport. There's a bunch of people that can help us. We have amazing PT and OT. We're pretty love them. And there's a bunch of great classes online that are free that I have just been obsessed with lately. So, but this can support mobility and muscle strength. It can decrease spasticity. It can actually help bladder and bowel. It can help your balance, reduce spasticity. If I can get someone, this was like a little victory 2 times this week. One patient came in and said, that yoga was the best prescription you ever gave me. And I'm like, it's not actually like a handwritten prescription, but I totally get it. I was like, this is your prescription today. You're going to go home and you're going to try this and you're going to tell me if it works. Like, think of it like that. Like, I'm going to try this. I'm going to see if it works. And I'm going to let her know. It didn't work. No, but she was like, that was the best thing I ever did. Her spasticity got better. She was able to decrease some of her spasticity medication. So then her fatigue was a little better. You know, it's just like a good thing. So same with a bunch of other exercises we have. Mood, almost universally, people are like, I didn't want to exercise, but then when I did, I was pretty happy I did. How many people have had that experience, right? We're all, yes, everybody. And then we want to promote independence and quality of life. We just have to find the right exercise for you. Okay. So that's what time of day, what's good for you. And that may be with a physical therapist. It may not, they're the specialists. So, all right. So what do we like for exercise? Again, very personalized. If everybody had access to a pool, I would be like, everybody's getting in the pool. But flexibility, gentle stretching, those kind of things. Some of my patients, I'm like, if you're tired, when you get in bed, just do these stretches, like literally right before you fall asleep. Like, that's fine. It's something. Balance, Tai Chi. Awesome. Sometimes you have to modify these exercises. My favorite, the seated yoga. So good for your upper body. Gets you from doing this little C-shaped thing we all do to just, right, we're all doing it. Everybody sit up a little straighter now. We're all doing it. To try to get our shoulders to roll back, to breathe more deeply, to stretch your arms. It just feels good, right? Walking has been studied immensely, incredible studies on walking. Maybe you need some assistance with that, and that's okay. That's what we're here for. Strength training, I have to admit, I never did it, but the studies are amazing. That's what, I got to work on something. That's what I'm going to work on. So we all have things we need to work on, and these things are hopefully going to help you. Is there any other exercise that anybody does that they would love to share that, oh, I'm not supposed to ask questions. Okay, sorry. All right. So just don't hurt yourself, okay? So listen to your body. Let us know what the speed bumps are. Like, I always think of MS as like, those little speed bumps they put in the garage or in the parking lot so you can't like Paul would not be able to zoom by. He'd have to slow down. Oh, actually, he'd probably just go around it. What I like to think about as MS is we get these speed bumps with this diagnosis. We know that. We got to be resilient. We got to be strong. We got to figure a way to get around these speed bumps so they don't get in the way of our happiness. So that's what we got to do with this exercise. But I also don't want you to do something that's not appropriate for you. So you want to make sure it's appropriate. So what happens? Sometimes people get too hot when they work out. We know that that's not good. Break your exercise into smaller amounts, right? Maybe do 5 minutes in the morning, 10 minutes in the morning, 10 minutes at night. Fine, something. Try to stay consistent. Hold your toes to the fire, so to speak. And definitely physiatry, PT, OT, all those people are wonderful. Use all the adaptive equipment we have out there. All right, so we talked about exercise. Let's talk about fatigue. So fatigue is a bummer. I bet everybody here has had some fatigue, care partner and MS patient alike, right? But how do we measure fatigue? I ask people, how you doing? How's your fatigue? I think my MS patients really know their fatigue. They feel it, they know it. Sometimes I'm like, is it a body fatigue? Is it a head fatigue? But we do have scales. We have a lot of fatigue scales too. So for research, they have actual scales that they measure. But we don't have really good, it's not like a blood test. I can check your B12 level. I can check your thyroid, make sure those things are okay. But we don't have like a blood test for fatigue. So it's a self-reported measure. Many like MRIs are very objective. EDSS is very objective. Fatigue is very twicky. It's very twicky. Silly wabbit. So subjective symptoms, open to interpretation, poorly defined, as many researchers will say. And there's no gold standard for measuring it, which makes it a real problem because it truly is one of the most common symptoms of MS. It's a lot of my patients will say it's their biggest complaint. And the problem is there's so many other things that can go into fatigue that mess it up, right? So let's say you have spasticity or in your legs, and so you don't sleep a good night's sleep. Well, you're going to be tired. What about if you have to pee 10 times at the night so you don't sleep very well, right? So all those things impact sleep, which impact fatigue. Maybe it's a medicine we get, whatever, right? So there's a lot of things that go into this. But even if we account for that, fatigue is a real bummer. I really just wanted to put this picture in because that dang kitten. Can you stand how cute that thing is? Come on. I can't have a cat because my son's allergic, but so sometimes my patients blame themselves for their fatigue, and I don't think you should do that. Like, it's such a common MS thing, and it's hard because people can't look at you and tell you're fatigued, so it's a hard thing to explain, but it's really important to go back to the drawing board and explain to your friends, care partners, coworkers, like, this is MS fatigue. I know what it is. It's very predictable for me, or it's not. It just helps them understand, because sometimes they will forget as well, and that's okay. And I also think my patients get tired of complaining about their fatigue and their symptoms, right? And I definitely understand that. When you come into the office, you're supposed to tell me this stuff. You never have to say, I'm sorry, I got so much to tell you. I hear that all the time, like, oh, I have this laundry list. I'm like, that's what we're here for. I get that. I think when you live with chronic illness, it's hard, right? So I think the important thing about talking about fatigue is, what are we going to do about it, right? Like, how can we help you with it? This is hilarious. Okay, so I put this up here. Hilarious only because I'm a nerd, I guess, but not a hilarious like Paul. Paul's actually really hilarious. But if you look at studies, so PWMS is persons with MS. In one study, 92% of patients say they have MS. In another study, 75% of patients with MS, 80% of patients with MS, over 3/4 of people, over 1 in 4 view fatigue, right? So these studies are just all over the place when it comes to quantifying how many people have MS. But I can tell you, based on all that, super common, okay? You're not alone, right? So the MS International Foundation defines fatigue as physical fatigue. So you can have, this is like the body fatigue that people tell me about, hard to perform tasks, need to sit down. And then there's cognitive fatigue, right? That's a little different. Thinking, concentrating, those things are more challenging. And sometimes it's both. I think most often it's both. But it's usually just a self-reported thing. So we know this is probably related to the biochemistry in the brain and the pathways that we see. Due to inflammation, the MS interferes with these pathways. And then we have abnormal signaling and pro-inflammatory cytokines. And again, if we have pro-inflammatory cytokines, how can we address it? Let's work on exercise and diet, right? So there are things that we can do. But there are lots of other things that we do. That's what iatrogenic is, Cabot's fault. Like disease-modifying therapies. Some of our older disease-modifying therapies caused fatigue, like absolutely, like our early ones. A lot of the drugs we use for symptom management can cause some fatigue, like baclofen, tizanidine, all those things, gabapentin that we use to treat pain and spasms. So all day long, this is what we're doing. We're just weighing the risks and benefits of how we're treating symptoms and the disease and what you're experiencing for side effects. So that's another reason why it's really important to not complain. Tell us you're not complaining. Tell us what your fatigue is, because maybe we need to re-examine your med list and be like, we should change that and see if you feel better. Okay. So we can get to the structure and anatomy of this. So the thalamus and brain atrophy have been linked higher to fatigue. They don't exactly know why, but that seems to be even very early in the course of the disease, we can see neuroanatomical changes, and these may be linked to fatigue. So this is an MRI looking at the thalamus, which is a deep brain gray matter structure. Oh, I have a pointer. Oh my God, it works. Where's that kitten again? So if this is a brain without MS and this is a brain with MS, this white thing here is an outline of the thalamus. So it's a deep gray matter structure. And here you're seeing it as smaller. So smaller thalamus is atrophy, and that has been linked to higher levels of fatigue. All right. Who doesn't love a cup of coffee though? I'm sorry. So, and then sleep issues contribute to fatigue, right? So great opportunity to just be like, okay, what am I doing wrong? So let's think of our lifestyle choices. Like sometimes my patients will be like, oh, my bladder's a mess and it's definitely my MS and blah, blah, blah. And I'm like, how much coffee do you drink? And they're like, 12 a day. And I'm like, oh, let's stop that. And then their bladder gets better, right? There's nothing to do with your MS, okay? But that's the same thing. Like sometimes you're so tired during the day, you drink a lot of caffeine and then maybe that circles back and you're not sleeping well. But MS sleep disorders are very high for all those reasons we already talked about. We also want to rule out things like sleep apnea, which can really contribute to fatigue, and also other medical issues. So we don't want to miss it. So, I did mention some of these other things, discomfort in the legs, restless leg syndrome, periodic limb movements of sleep. These things happen in all humans, but we want to make sure that we're treating all those things. So over half of MS patients will complain of sleep dysfunction. All right. Don't forget, let's treat the bladder. It's sort of the Achilles heel of MS. Yes, Achilles heel. Thank goodness for excellent urologists. They're the best. Anxiety, and thank goodness for excellent mental health providers. And then sometimes it's us and our yucky, bad sleep habits. Like we need to work on this. We got to take ownership of our bad sleep habits, right? Can't just sit around, watch Netflix, go to bed at 2 a.m. My favorite thing, and I am not a marriage counselor, is when a care partner and a patient come in and the patient's telling me about their fatigue. And I'm like, how's your sleep? They're like, well, it's okay. And the care partner's like, what? They're giving me the eyebrow roll. They're going, and I'm like, what's going on? They're like, he or she is playing on their phone until like 1 a.m, and I'm like, oh, busted, right? Busted. You're so busted. It's so not good for your brain. So passive scrolling is not good for you. Passive watching television, not good for you. It will eventually lead to cognitive mush. This has been studied. You need to put that down and pick up a better hobby. Definitely talk to primary care, us, whoever. Let's help you with that. All right. Depression, fatigue, and pain. These are circles we cannot split apart. So let's make sure we address all of them. I'm not a psychologist or a mental health provider, so we try to get you connected with some really good people. But those things can happen, and we just don't want to ignore it. Okay. Fatigue and depression are just hand in hand. They even call it fatigue and cognitive issues, pseudo dementia, right? Like you're not demented, but you feel it because you're so depressed. Okay. So we want to make sure that those things get addressed. Did I increase your fatigue? We already mentioned that. I forgot to mention some of the bladder medicines will also cause fatigue, and some of the antidepressants can also cause fatigue. So other medications, definitely check in because maybe it's something your primary care gives you. So there was a study looking at persistent fatigue, and what they looked at here was how to rule out common medical conditions. And to be honest, my patients are the ones who figure this out, right? Because you're telling me the story. Sleepiness, insomnia, snoring, let's make sure you don't have a sleep disorder. Treat that. Let's make sure you don't have depression or anxiety and treat those things. These make such a difference in your quality of life. And a lot of the things that we talk about, are not pharmacology. Like I'm not giving you a pill first. We try the non-pharmacologic things first because we know that if I give you a pill to help you sleep, which some people need, maybe you'll have side effects from that too, right? So if we can limit the amount of medicines we're giving you, we really want to give that a try first. So that's a good thing. So again, get you exercising, that kind of stuff. So why does it take a village? All those things, okay? It definitely takes a village. So sometimes you need your primary care to help you with some of these issues, a sleep specialist, a mental health provider. I think we all benefit from these PT, OT, and rehab specialists, bracing specialists, excellent radiologists to help us interpret complicated scans. All these people, urologist, Yahoo for the urologist, making a huge difference. Don't forget other aspects of your care. So nutritionists, cooking class, okay? Spiritual groups, volunteering. Volunteering is an excellent way, especially if you're retired, to stay engaged. Hobby groups, plants. Anybody like plants? House plants? I murdered a bunch recently. I feel really bad about it. Extended family and neighbors, reach out. call a random relative you haven't talked to in a while and just catch up again. And then meditation and online support groups. And don't think that there's one path. There's not one path or algorithm to treating MS, and there's not one path or algorithm for your wellness. It's very personal, but definitely keep asking people what they do and get some advice. So that would be great. All right, so that's the same one. These are some resources on wellness. So I'm going to jump into, and I'll do questions at the end. Normally I would do them there, but Stuart did want me to touch base on a couple other things. And to be honest, because I just got back from the international conference, that's a week-long conference just talking about diagnosis of MS and all the research that's going on. It's like a million hours of lectures. So I'm going to do a mere skim over the top of that. And then I would come back for a research update. Like I would go online to the MSAA or some of these other programs that have amazing research updates. So there isn't a new medication or something that came out like today that I need to tell you about. There's nothing new like that, but there's certainly a lot of cool research that I will share. But I think this is an important topic that was discussed at ECTRIMS, is accessing care in rural communities. Here in Manchester, we don't really have that problem, but some of my patients come from pretty far north or south or west, not too far east because you run into the ocean. But, this is true all over rural America. And some of the studies I'll show you go back a couple of years and things are getting even harder for various reasons. But rural America really is facing a very big challenge. I mean, not just with specialty care, primary care. So this is a big challenge for people, and how to keep them engaged in healthcare is super important. Geography, like some patients, if you have to drive like up, you can't get there from here, right? So you down and up. It could be like 2 hours to get to your doctor. Maybe if you don't have a reliable car or a person to help drive you, this is a big obstacle. You may not have, people don't have internet everywhere, which is shocking, but true. And local strategies can be really lacking. So there's not equitable care for our patients with MS, which is a real shame. So that's important. Oh, and I apologize. One of my slides dropped out. So, but we use a lot of telehealth to help us with coordination of care in patients who are living in rural areas. If they don't have a computer, there is a foundation that will help provide a computer to a person who doesn't have a computer, because getting on telehealth can be unbelievably helpful, because then we can see them and we can talk to them, and it just makes such a big difference, so much better than just calling them, And the other thing, there's a couple programs where primary care doctors can, call and talk to MS specialists around the country to get so they can just drive to their primary care office, but still get in touch with a neurologist that can specialize in care for them. So it's a really cool time using the technology to try to help people who live in rural areas access the care they need. But it's hard accessing care no matter what. And now you throw in 2 hours away or 4, you think of people in like the Dakotas or, way out in the middle of nowhere. They're really struggling. Paul probably knows, he drives his motorcycle all through those areas. So, all right. So one of the big topics, have you guys heard of progression independent of relapse activity? Yeah. So that's good. You've been reading. So we know that with relapsing forms of MS, we have a lot of really excellent treatments. I mean, we have over 23 treatments for MS right now, right? And counting. But we also know that one of the biggest unmet needs for our patients is when they continue to have disability progression despite no change on their MRI. And I always feel like I need to apologize here, because when people have a stable MRI, I'm like, good news, you have a stable MRI. And you're like, yeah, I still feel terrible, right? Or I feel like I'm getting worse. It's not to say you're not. It's just one measure of how you're doing, right? So the MRI is a very objective measure, and I am happy there's not something new on that. But we also understand that sometimes MS can get worse despite that. So that is an unmet need in our armamentarium of medications for patients with MS. So we know that patients stop having relapses as they get older, right? Like the natural history of the disease is you see very active inflammation earlier in the course of the disease. And as we get older, that inflammation tends to peter out. However, there's still stuff going on. So there's a ton of research looking at this. How do we measure that? How do we even measure that? Like, I think I was talking to you, Mary, the other day about, if we try to measure remyelination, how do we even measure that? We don't have an MRI that shows remyelination. We have an MRI that shows demyelination, right? Like, we have to shift our thinking, but all the way back to the beginning of how we even measure things. So the big struggle is how we measure these things. We can look at an MRI and see different measurements, and we can look at different scores like cognitive testing and mobility and 9-hole peg tests and all those other deeper dives. But it is still tricky. So we don't really have excellent measures. And these exact mechanisms, we don't really know. Is it inflammation? Aging is the biggest predictor of disability progression. But chronic inflammation and neurodegeneration are named as one. So there are this new group of therapies called BTK inhibitors. So this is a class of medicine which is not approved in the United States right now, so don't worry about it. I'll high level it. But these are drugs that cross the blood-brain barrier, so they access the central nervous system. And they can target both B cells and microglia. Microglia are other cells in your brain that support brain function. So there's a whole host of them. There's a whole bunch of them. So these drugs are all really different from each other. So it's, a lot of times we talk about some drugs like a class effect, like, oh, these therapies are all very similar. But I think these therapies are all kind of different. So it's going to be really neat. And these medications we're hoping will fill that gap, but we don't know because number one, it has to be safe, right? We don't know if it's going to hit that safety mark. And number two, we don't know who it's going to be effective in yet, so we don't know if it's going to still attack that inflammation like the other drugs or not. So there's a lot of question marks here, but I think they're coming pretty close, right? So you probably read about these. One of the drugs the information was supposed to be released before the conference and it got pushed back to December. So we were all a little bit like, but I think you will see something like this soon. So here's a little update on some of the top contenders. So you do not have, this is not the test at the end, just so you don't have to have anxiety. But fenebrutinib, tolobrutinib, remibrutinib, and these are all BTK inhibitors. Again, not available yet. Still not sure how we're going to monitor safety. That's in the works. And not sure who the perfect patient is yet, right? So there's a lot of but exciting because this is a huge unmet need for our patients to slow disability progression. Because despite our terrific medications that we have, some people still progress. This is also a really cool topic. This comes back to that point of how do we measure it? So the holy grail has been like, can we just do a blood test to see how you're doing instead of keep putting you in that poor MRI machine, right? Woohoo! So there is some really good data looking at especially these two biomarkers. These are blood tests called NFL, so neurofilament light, and GFAP. And these two tests have been used over time, and they're not perfect yet. They're not perfect alone either. I think that's the important thing, that if you just looked at one, I don't think it's going to give you enough information. But there's this one test that we can offer in the office if you want, called Octave, and it looks at a whole host of different biomarkers, and maybe that will help us figure out progression so I don't have to tell you your MRI is stable and you're like, but I know I'm not feeling great. Like that may be helpful. This is a really interesting ongoing thing, and it just got more funding to do progressive studies. So I think you'll see more of this in the near future. I love that we'll have hopefully more tests to help you guys figure out what's going on too. Another huge topic is when to stop therapy, right? So this is a good problem to have. Like when I started, we didn't really have a whole lot of therapies, and now we're talking about when is it safe to stop them. So there's no algorithm for this. It's always going to be a one-on-one conversation with your doctor. It's a complicated topic. We know that patients who are pretty stable and doing well they just rehashed a whole bunch of data. Patients under 60 who discontinued therapy still had some disease activity, it looks like, but over 60 less. But then we're talking about progression, right? So is there progression? So I think it all comes back to we'll have a better answer to this when we have better ways of measuring it, right? I think that's going to help a lot. It also matters like what drug you're on, what you're coming off, how's your disease been, all these other factors. So it's not a simple question. Awesome. So I think the important thing is to always work with your team, and make sure that you're answering all your questions. So how about you guys look at what you got from the other table and share with me one idea you might have to help treat one of the symptoms that you got from this program, one of the symptoms that you have on that list. What list? What do you got on there? What are people talking about as complaints or symptoms of MS? So left-sided weakness, fatigue, and mental health were on that list. What do you guys want to do about it based on what you got out of here? Is there any technique that you would use to treat fatigue, wellness from this? Just don't walk around. I know.
Oh, exercise more. I find I've been off the exercise. I've been off the exercise habit, and I realized when I was on it, I felt better, even though.
Awesome.
Yeah.
Perfect. Round of applause. Round of applause. So that's her goal. Okay, so it's going to be personal. All right, next table. And did you have a list of symptoms? All right, who wants to speak into the microphone? Could be a care partner, could be a patient.
I think we agree with the cognitive numbness and tingling and nerve pain.
Good. All right, cognitive. Hit it. What do you guys want to do? What's a technique that might help cognitive?
Mindfulness.
There you go. Perfect. Stop moving. Got it. All right. Mindfulness. I love it. All right. Next table. And it's a team effort, so feel free to jump in. What was on your list of symptoms? Spokesperson.
No.
They're fighting over the mic.
I know they all want it.
The three things, here's three things: more energy, better mental health, and stronger body.
Great. Better mental health. What resources do we have for better mental health? Sleep. I love it.
Therapy.
What was it?
Your
Therapy. A
fellow
good therapist.
Yes.
Bravo. Table 3. All right. Next table, Paul. You got your trekking poles out here.
All right.
All right. Who's a spokesperson at your table? Mary, not you? Mary, come on. We got one. Give me one.
Different or better ways to communicate.
I love that.
A doctor, your
Yeah.
PCP, because I feel for me, they don't listen to me.
Awesome. So what are some techniques you would use to help communicate? That could be doctor, family, friends. We talked about how important it is to have honest communication. What would you do? Anybody at the team? Get a different doctor. That's funny. I love it.
I recently changed my PCP because of that.
Good for you.
Yeah,
Yeah.
all
You're the boss.
Yep.
Don't ever forget it.
That's it.
Yeah. I love it.
You
All
could
right.
stalk them, right? Go to their house. And
That's Paul would have that answer.
you could yell. You could yell during the
I love
exam.
it. But yes, John, honest communication can be really challenging. So I always tell patients, write a list of stuff you want to bring to the appointment so we don't blow through everything else and forget to tackle your question. All right, Richard.
As simple as it sounds, taking a nap in the afternoon.
I love it. Anybody else like that one? Great idea. Fatigue.
Recharges everything.
Yeah.
Everything
fixes
gets
everything.
recharged.
Love it. Just don't make it a 3-hour nap because then it's hard to sleep at bedtime. Great. All right. Next table.
All right, I guess she's gonna make me.
I love the spokesperson. Here we go.
This here says social interaction. Now, we belong to a support groups, and that kind of helps out a lot.
It helps a lot. All right. But you have to be brave to go to that support group the first time. Good for you guys.
Yeah,
You know?
we're brave to take it over too.
Yes. Or a little crazy. So, all right. Next table.
Patience.
Having patience.
Yeah, having patience.
How would you guys address having patience? What tool would you use from the toolbox?
Breathing, mindfulness,
Great. Yeah. Breathing.
meditation.
Maybe not being so hard on yourself. Yeah. So that's a hard one.
Yeah.
That's a hard one. Yeah. It's a great one though. I think All right, there's still a little discussion. All right. But anyway, I just wanted to thank you guys for participating and getting involved a little bit with your spokesperson and your table. Round of applause for the spokesperson. Way to go. And I'm happy to answer questions if we have time.
Does menopause affect the MS?
Awesome question. So there was literally a really recent paper that says it doesn't like technically make it worse, but people feel terrible during menopause. And there are studies showing that as well. The biggest problem with menopause, well, there are lots, but one of the sleep, the fatigue, the sleep is disrupted in menopause, and that really bothers a lot of patients. The heat of a hot flash can make all your symptoms worse. I forget who it was. I had a patient who came in once and she's like, so I'm sitting at lunch with my friends and they were all telling me about their menopause symptoms. And I swear to God, I thought they all had MS. Like they're so hard to tell apart, these symptoms, right? So, I felt really relieved about this most recent, now I wish I could, it was literally like very recent article that just said this doesn't have, like long-term, like people don't just go during menopause, people that are stable during menopause. So I need to review that because it literally was this like last week. So timely question, very well done. Thank you. But I hear that, 80% of our patients are women. A lot of our patients are diagnosed in their 20s, 30s, maybe even before they've had children. And then they go through that and then they go through menopause with us. And, so it's a lifelong adventure with MS, right? So we go through all of life's ups and downs and MS's ups and downs. So that's an awesome question and a good thing to keep in mind.
Great. Thank you, doctor. I'm going to take a question online because it's similar to what you're talking about, but there's a man online. Okay. There's a man online that wants to know what he can do to get functioning back in his lower portion of his body that he needs to be able to feel more because his wife feels inadequate because he cannot feel and they don't know what to do.
So I think he's talking about sexual dysfunction. Is that correct?
Yeah.
Yeah. So we know that MS can impact sexual function for men and women, and it can be really complicated. I feel very fortunate here. We have a urologist that is excellent at helping patients with sexual dysfunction for men and for women. It's tricky though, especially if there's lack of sensation. I think that's number one, just to make sure there's not a mechanical problem that can't be fixed that way. Then the other part is really good communication. So this may take a therapist, right? Changing roles, changing physical bodies, changing dynamics. You don't want someone to feel bad about themselves. That will just compound the awkwardness, right? So you want to make sure that you have an open discussion about what I can do and what I can't do, what I'm comfortable with, what I'm not comfortable with. I mean, I would definitely start with the urologist who specializes in sexual dysfunction. And then I would augment that with a therapist, for the changing roles. But it can actually, there are some wonderful studies looking at deeper relationships with patients with MS, with different forms of intimacy, holding hands, having quiet time together, doing things together that are also very romantic and not always just thinking of sex as an act, but thinking of a relationship and connectedness. So it can even make it a deeper type of connectedness. But that's an excellent question, and patients should never feel shy to bring it up in the office. I think sometimes it's frustrating because there's not as much as we would like to be able to do, but we can refer out. Another thing that can interfere with sexual function, often spasticity, bladder dysfunction, fatigue. So all those things are good to kind of talk about too.
What if you don't have menopause, but you're having symptoms of menopause?
Oh, great question. So what I would do is make a list of the symptoms, make sure to go see your neurologist, make sure they're not MS symptoms. And if they are, we could try different things to try to treat them. And then I would check in with a gynecologist. So gynecologists are like, I don't do hormone testing, and things have changed a lot in the last 5 years with regards to symptom management of menopause and other symptoms of menopause. So you want to make sure someone's not in like premature ovarian failure or something like that. But yeah, they do a lot more than they used to. Like things have changed quite a bit in the last 5 years. So there's a lot more optimism, I think, for our patients who are really suffering with menopause symptoms. Great question.
I've seen aquatic centers in like metropolitan areas, in cities, but this is about rural.
Yeah.
Are there any resources for us outside of where there
I'm
are?
so glad you asked.
Okay.
So the question is about, where
It's getting really cold.
it's
too.
really cold. It's going outside the pool. You can't go in the lake. Like a lot of my patients will go in the lake in the summer, or the ocean, which is so freezing. But the YMCA, there's a YMCA in Goffstown, Manchester, Concord. I don't really know the area. Where? Nashua, Portsmouth. So the YMCA is excellent. And they usually,
Actually will give discounts to
Yes.
use their pools.
Yep.
They have actual like a 6-month or yearly rates, or they charge like $10 or $20 to use it and to try it out.
Yeah, so as long as you can get in and out of the hotel pools, and a lot of them do have access, so they will also do that. And that's an awesome recommendation because a lot of these pools aren't being used during the day or hardly ever, these hotel pools. But you just have to make sure those are safe enough for you. I think the other fun thing about the Y is they have a lot of fun classes. So I have long dreamed about having an MS aquatic class, but it never seems to work with the YMCA. So if anybody has a friend that works at the Y and can hook me up, let me know. There's also a rehab pool at Elliott for intense rehab. But honestly, I think if we could get a aqua Zumba class or something, it would be so much fun because you're floating around, right? Like it's pretty good.
Wentworth, they have their
Wentworth
own,
has a pool.
they have that they have their entire gym.
Yes, they have a wonderful
And they
center
have
as
that
well.
whole center.
Yeah.
That they have classes in
Yep,
there.
and they do, and so does the Y. So you might be able to just join one, but wouldn't it be kind of fun to have an MS one that we got funded or something? So just a thought. So awesome. I love the pool. Good job. Because I didn't actually mention it. So she's paid. I paid her. She's a plant. So
I wanted to let you know that going back to rural America, there are people on there that, we do all these programs in rural America, and it's not just what you mentioned earlier, but there are also those that cannot drive because of their multiple sclerosis, and they don't have family to take them to see a doctor an hour away or better. They don't have buses or trains to hop on like those that are in better areas of the United States. So it's not a matter of just not having internet. It's not just not having that either. And that's why we need the support groups back. So, pre-COVID, we had support groups all over the United States. And there are many groups that are in very rural areas in the United States that are still functioning and that are growing and getting back. And, this is why it's of such great need, though, to reinstate those support groups and for people to stop being afraid, because they're not going to get any worse than if they got the flu at this point in time. So get on out there again and be part of the world and let people be functional with meeting other people and being functional and being able to learn from their communities about MS. Okay, that's just my rant. Now going forward, the next question for you was, how do you explain non-relapsing SPMS, which is a potential medication to be coming out, versus a person who simply has SPMS?
There's always been, relapsing MS, and then it transitions into secondary progressive MS. So relapsing MS, you have to have discrete relapses that come and go. And the hard part about when to define when someone has progressive MS is when they stop relapsing, but also if they're being treated and they're not changing, like how do we measure different subtleties of that? But many patients who get secondary progressive, and we're pushing out that window. So that's the important part. The medications we have now and treating patients now, we're seeing a longer and longer time before patients develop progressive MS. The biggest predictor of secondary progressive MS is how long you've had the disease, whether you're treated or not. So how they're looking at this now is the insurance coding just changed. Insurance coding doesn't mean anything to biology. I think that's really important to understand. Insurance coding is just what they make us put on your chart so that if I order a test and I don't have the right code on there, they can deny it. So my theory. But they separate, and we do know that there's active secondary progressive MS, and non-active secondary progressive MS, meaning you can still have slight activity either on your MRI or with your symptoms, relapses, but overall you're still declining. That's active secondary progressive MS. Non-active secondary progressive MS means you're just continuing to decline and there's no evidence of disease activity, active disease activity. So that is our struggle, and that's what I was talking about with the biggest unmet need. We all know we want a change for that. We need meds for that or something, and which is why I spent this whole time talking about wellness, because wellness can help, healthy diets, healthy exercise. Not that anybody is causing that, but the inflammation of a lot of that can help with progression. So then we need to find other medications that may work differently than the pathway of the medications we have now. So the medications we have now very strongly work on relapsing forms of MS and inflammation, but we know there's neurodegeneration, and that's where our meds may be falling short. So that's where those BTKI drugs are coming in to help try to address this need. And the real question is, at what point do you use them? Like at what point in the disease? And are they safe enough? So I hope I answered that question.
Great, thank you. Next one is a person is asking right now, what does BTKI stand for?
Bruton's tyrosine kinase inhibitor.
Wow, you say that so good too. Thank you for that.
Yeah.
All right. The next one is asking, can you describe for us more, please? We're hearing about smoldering MS. Can you tell me what this actually means?
Yeah, I think it's a wonderful marketing term, to be honest. I think it's progressive MS. So it's really progressive MS. It means your MS is still kicking around in there. It's not causing these big acute relapses, but it's still bugging you. And that's really what smoldering, that term smoldering means. It is progressive.
Great.
A sexy term.
Awesome, thank you. So Kevin wants to know, see, there's the Kevin, all right? Kevin wants to know, he said that you were talking about online mindfulness and meditation classes. Are there any links to these that you know about?
So we offer one for our patients that's online, and it's the Cabot Zen model. I don't have other specific links, but there are dozens of online mindfulness classes. You just want to find, I don't know about you guys, but you got to find a teacher whose voice doesn't want to make you grate your nails on the fingerboard. I think that's the term. You got to find someone who you like their style. That's all. So you may have to try 3 or 4 of these classes and don't give up. Like that would be my advice. If you check out, a mindfulness class online, just make sure that you try it. And if you don't like it, try a different one. Don't be like, well, this isn't for me.
Great.
It may not be for you, but at least give it a couple tries.
Great. My response to that is Google, type in online mindfulness classes, period. Okay. All right. The next one wants to know more about B-cell depleters. Can you tell us more about these and why are they so much different than other drugs that are out there?
Sure. So we're very lucky. We have, over 20 medicines to treat MS, and we separate those into different categories. So our early meds were things like interferons, Copaxone. Then we got Tysabri and natalizumab, which is very different. And they work very, very differently from each other on how they impact the immune system, right? So natalizumab is our first really high efficacy medicine, worked really well to stop MS. And then a couple of years later, we got the first pill, Gilenya. Totally different mechanism of action, shoves lymphocytes into the lymph nodes, really well effective. But now there's 4 of those. So drugs are in that class. So we have sphingosine modulators, we got Gilenya, we got Zeposia, we got Mayzent, Ponvory, right? So sometimes they're all in the same class. They're going to have very similar risks and benefits. Okay, so we have those. And then we have we have a couple other pills. We got the fumarate, so that's dimethyl fumarate or Tecfidera, and a bunch of other of those in that class. And then we got teriflunomide or Aubagio, which is a once-a-day pill. It's the only one in that class. And then we get the B-cell therapies. So the B-cell therapies were a huge breakthrough. Some people were using off-label Rituxan for many years to treat MS, but we didn't know the recipe
We didn't know the dose. We didn't have a lot of studies, and it was often not approved by insurance. But then Ocrevus came along, and Ocrevus was the first B-cell therapy, and the researchers found that this was super effective in treating MS. And now we have 3. So we're very lucky. So I tell patients we have 3 B-cell therapies. We have Ocrevus, Kesimpta, and Briumvi. They're all excellent at treating inflammation, reducing disability progression, and stopping inflammation on MRI. So these drugs are all very effective. How you get them into your body is different from each other, but they all have very similar risks and benefits. So there are most effective, B-cell therapies are very effective at treating the inflammation, MRI changes, but nothing's a cure, okay? So we don't have a cure, and all our meds have potential risk and benefit, right? So we are suppressing your immune system when we do those drugs, and there can be potential consequences. Now, as we age and our disease becomes less inflammatory, that's when we have to start making decisions about when is it safe to keep, if the natural history of the disease is that it's going to stop being inflammatory and relapsing, is this the right drug? And we don't have the answer for that. So that's the one-on-one conversation with your doctor that you need to have. B-cell therapies are the most commonly used therapies in the United States. So,
Okay.
And around the world.
Thank you so much for that answer. Now I'm going to ask you about a few others. Person's asking about biosimilars. Why was there a biosimilar approved and not being used?
Biosimilars are drugs that are, so generics are small molecules like pills and things that you can have. So so a lot of our drugs are generics, like when they go generic, like dimethyl fumarate is Tecfidera, and we can get that at Mark Cuban's pharmacy for really good deal. Same with teriflunomide or Aubagio. But other drugs that are biologics have biosimilars. And it really would depend on a person's insurance. If insurance insisted they switch to that. I have not run into this yet where insurance forces my hand and makes me use a biosimilar, except for Rituxan. So I would not have the inner workings of why it was used or not used. That would be up to someone in a business position.
Okay, thank you for that. I think they were asking something a little bit different, though, that a specific medication was approved as a biosimilar for multiple sclerosis and not yet being marketed. And they didn't know if you can answer this. And that was the natalizumab.
Yeah, the Tyruko. So I haven't had to, I know when it first came out, I've seen ads for it when I was in Europe, but I haven't ever had a representative come to my office and explain it to me. I've never had an insurance company tell me I have to switch my Tysabri patients to that.
Okay, thank you. Are there any
similar? I really wouldn't object either, to be honest. Like if it was proven to be similar and work the same way, I think the trick for natalizumab is the JCV antibody testing.
All right, great. Thank you. Thank you. There's just so you know, you might hear me trying to overspeak you or whatnot, but there's a delay, and I don't know where the delay is on my end or on your end. So I'm sorry for that. Okay. All right. Now, are there any in-person questions? Because otherwise, I have more online.
No, I think we could handle maybe 1 or 2 more, but otherwise we don't want to glaze over everybody, right?
What is the difference between Ocrevus and Ocrevus Serono? Yeah.
Oh, that's very easy. Ocrevus Jr. has 2 extra letters after it.
I don't think anyone could say it better than Paul, so I don't even want to come after him. Coming after Paul speaking on motorcycles is like, oh God. So basically they took Ocrevus and they made it an injection into the abdomen. You still have to come into a doctor's office. You still have to, I think it's 10 minutes. You have to have that port put in and then be monitored after the dose is given. So it's the same medication, same risks, same benefits, just again, given another way. Yeah, sorry, same drug though. Yeah, ocrelizumab. Excellent question. Thank you.
We have a person that wants to know the difference between secondary and primary progressive MS.
So to be honest, I think someday we're going to get rid of all these little subcategories. But right now, primary progressive MS starts typically with no relapse, right? So patients cannot identify ever having a symptom that came and went. They cannot identify optic neuritis. They cannot identify that they had numbness or tingling that came and went, transverse myelitis that came and went. A lot of people with primary progressive MS merely have slow walking problems. They maybe have been getting a foot drop, for a few years. They never even saw a doctor till they tripped, right? And then they're finally like, oh, in retrospect, I have been tripping over this right foot for years. So a lot of times it's a slow progression of symptoms, whereas secondary progressive MS starts as relapsing MS and then morphs into secondary progressive MS, where they're still having slow progression of symptoms, but no acute relapses. So there's an excellent explanation of that on the MS Society website that might be really helpful.
Great. Thank you so much for that answer. The next one is, will BTK inhibitors be able to be used with any current medications as a combination therapy?
Love that. That is a very, very good question. I asked that same question in my head. And I don't have an answer because right now they're studied as monotherapy. Because as soon as we start combining medications, we have now doubled immunosuppression, or we're suppressing the immune system in two different ways. Is that a bad thing? We don't know because no one's done it yet. But you think of other disease states, they do that all the time. But we don't know if it's safe. And it may be, something we do early in the course of the disease, later. I think there's so much work to be done on where we place these therapies and the safety of them that hasn't been hashed out yet by the big societies and the academics to figure out where to put those drugs. But I'm really excited to have the opportunity, and I think it'll be soon. I think it'll be around the corner. And I have to say, this is the first time I felt this way, but some of the research that was at that conference was so incredibly optimistic about finding a cure for MS that I have a whole new, whoa, so excited about this research direction that MS is going in. So really looking at, viruses and different treatments, for EBV, all this cool stuff. So definitely pop open the research update on the MS Association of America website, cruise through that a couple times a year, because it'll fire you up. It'll get you excited.
Okay, great. Thank you so much. I want to thank everybody for being online and in person today. And I want to thank our exhibitors and as well as our sponsors. I mentioned the name of all the sponsors earlier in the program. Dr. Cabot, I'd like to thank you for coming out here today. Thank you, thank you, thank you. People online appreciate you. And I'm sure the people in person, thank you. We're going to call that a wrap and hang it up. Thank you.